Yes, we are good to go. Thank you so much for joining us for this webinar today. I'm sponsored by Kinvent. My name is Jillian Erickson. I am a physical therapist at Hospital for Special Surgery in New York City. I am a board certified specialist in orthopedic physical therapy, as well as a certified manual physical therapist. And I specialize in the young athlete. So that is what we are going to talk about today. So let me first share my screen. Okay. I know not everyone loves to treat the adolescent, but I think most clinics have at least a handful. So I think it's important that we recognize that they are different than adults and recognize what to look for with diagnoses that are specific to kids or adolescents. So today we're going to talk about the young athlete's knee, common non-traumatic diagnoses, and rehab considerations specific to the adolescent population. We're also going to discuss how we can utilize the Kinvent bubble or pressure sensor and force plates with this patient population specific and why it is advantageous to use it. So our learning objectives today is you will be able to describe the basic structures of the immature musculoskeletal system. You will be able to describe the diagnoses presented in this webinar. You'll be able to formulate an appropriate management plan for the diagnoses presented in this webinar, and you'll be able to understand the differences in motor control strategies in the young athlete because they are different than adults. So first, we're going to talk about the skeletal differences. So the growing parts of the bone include the physes or growth plate and the epiphyses, which is the rounded portion of the end of the bone where the joint is. Traction epiphyses or apophysis are located at the site of attachment of major muscle tendon to bone are subjected primarily to tensile forces. The apophyses contribute to bone shape, but not to longitudinal growth. As a result, acute or chronic injuries affecting traction growth plates are not generally associated with disruption or longitudinal bone growth. We're going to specifically talk about these later. Pressure apophyses, which are situated at the end of the long bones, are subjected to compressive forces. The apophyses of the distal femur and proximal tibia are examples of pressure apophyses. You can see this on this picture here, the proximal tibia, the distal femur, and then these line right here is the growth plate. The susceptibility of growth plate injuries appears to be significant during the period of rapid growth. So when looking at a kid's knee or an adolescent's knee, we want to think about the common diagnoses that they could possibly have and how they're different compared to what you might see in an adult or an older adult. So in children or adolescents, most commonly you may see a patellar subluxation, the tibial apophysitis, which we're going to talk about later, a patellar tendonitis, which is more of an acute inflammatory injury, opposed to a patellar tendinopathy with more degenerative changes that you might see in an adult. Or you may have referred pain from a slipped capital femoral apophysis, or osteochondritis dissecans is more common in kids than adults. So overuse injuries and burnout in the youth sports, a position statement from the American Medical Society for Sports Medicine. So overuse injuries occur from repetitive submaximal loading of the musculoskeletal system without adapted rest to allow for structural adaptation to take place. Overuse injuries unique to the young athlete include the apophyseal injury and physeal stress injuries, which we talked about earlier. The National Council of Youth Sports survey found that 60 million children aged 6 to 18 participate in some form of organized athletics, with 44 million participating in more than one sport. Risk factor for these overuse injuries is prior injury. It may be associated during period of adolescent growth spurt and then higher training volume. When treating the young athlete, you want to make sure you ask them about their training volume, about their usual schedule. Early specialization may also increase the risk of overuse injuries and early burnouts. You want to talk to them about, are they only playing one sport? Are they playing multiple sports? So looking more closely at apophysitis. So this results from a traction injury at the cartilage and bony attachment of tendons. Frequently occurs during rapid periods of growth. It may remain symptomatic until closure of the apophysis. I think this is really important to know and to educate our parents and kids because we're not necessarily looking for 100% pain-free when treating them. They may not be 100% pain-free until those growth plates close. And then avulsion can occur with forceful muscular contraction at end range stretching of the osseous structure. So we have this picture here, and the two diagnoses that we're going to look at is Sinding-Larsen-Johnson syndrome, which is apophysis of the inferior pole of the patella, which you can see my cursor right here, and then Osgood-Schlatter disease, which is right here at the tibial tubercle apophysis. So looking specifically at Osgood-Schlatter disease, or OSD, up to 10% of adolescents are affected by OSD. It's a common osteochondrosis pathology during adolescent growth. Single sport athletes have a 4 times higher risk of developing patellar tendinopathy and OSD than multi-sport athletes. So going back to that early specialization we talked about earlier. Exact cause is unknown. It's thought to be secondary to repetitive microtrauma of the tibial tubercle or due to tight quadriceps. Symptoms are bilateral in 25 to 30% of patients. It's more common in boys than girls, and it's most common boys 10 to 15 years and girls 8 to 13 years. In severe cases, it can cause a partial avulsion of the tibial tubercle. Clinical presentation of OSD. So the kid will have anterior knee pain localized to the tibial tuberosity. Most often they'll recently have gone through a growth spurt, so it's always important to ask how much they've grown that year. They'll have on and off pain for a period of months, increased pain with squatting, stair climbing, jumping, running, forceful knee extension contraction. Quadriceps and hamstrings may be tight, and they may walk with a quadricep avoidant gait because of the pain that they feel when they engage their quad. On physical examination of OSD, they'll have tender and swollen at the tibial tuberosity, knee pain reproduced with resisted active knee extension or passive hyperflexion. And in severe cases, radiographs may show that avulsion of the apophysis that we talked about earlier. This radiograph shows prominent and fragmented anterior tibial tubercle with adjacent soft tissue swelling. Radiographical findings. So to diagnose this, they may use X-ray, CT, MRI, and ultrasound. The thickened patellar tendon is better noted on the ultrasound compared to the plain radiograph. This is an image, bony prominence over the tibial tubercle of the lateral knee. Kind of see right down here. This is a great diagram to look at treatment for Osgood-Schlatter disease. We are going to discuss more in depth on conservative treatment, but in some severe cases, surgery is an option. The two most common procedures performed are ostial excision and tibial tubercle prominence resection. Sinding-Larsen-Johnson syndrome. So this is repetitive traction at the inferior pole of the patella, commonly seen ages 10 to 14. It can take 12 to 14 months for symptom resolution. It is unusual for pain to persist after fusion of the apophysis. This image here shows minimal fragmentation of the inferior patellar pole. Clinical presentation of SLJ is similar to OSD, intermittent anterior knee pain, pain with activity, gradual onset of several weeks to months, pain with jumping and running, and localized tenderness over the inferior pole of the patella, which is the main difference is the location of the tenderness. So radiographic findings and classification. So the staging of SLJ is stage 1, normal findings, stage 2, irregular calcifications at the inferior pole of the patella, stage 3, coalescence of the calcifications, stage 4A, when the calcifications are coalescing into the distal pole, stage 4B, a coalesced calcification mass separated from the patella. This image is of a 12-year-old male soccer player at stage 3. He is symptomatic with tenderness over the inferior pole. So I just want to touch a little bit on severe cases. A patellar sleeve fracture can happen. So this represents less than 1% of all pediatric fractures. This is where the inferior pole avulses along the cartilage and retinaculum. Acute forceful muscle contraction of the quadriceps muscle typically seen during jumping activities. It's frequently missed on plain radiographs. MRI helps to avoid this misdiagnosis. And the kid's going to be in a lot more pain than the usual Larsen-Johnson syndrome. They're going to have difficulty weight bearing, soft tissue swelling, unable to actively extend this knee, and require surgical fixation. Since this is not commonly seen, I just want to do a small case report just so you guys can keep your eyes open for it. So 12-year-old male athlete, chronic anterior knee pain, 4 months, diagnosed with SLJ syndrome. After 3 months of conservative treatment, he initiated high jumping activities. He initiated back to sport to high jumping activities. 1 month later, patient reported severe knee pain and loss of function after performing a high jump. He presented with swelling and painful left knee, difficulty weight bearing, tenderness over the patella, limited range of motion, palpable defect of the patellar tendon, and unable to perform a straight leg raise. Plain radiographs and MRI confirmed inferior pole patellar sleeve avulsion. Surgery was indicated. So now we're going to talk more about the conservative treatment of OSD and SLJ. So relative rest is the first thing. We want to maintain their activity, but at a low level of pain or no pain. Like I said, they may not be pain-free until their growth plates have closed. So we're not necessarily saying no pain at all, but definitely a low level. We want to address range of motion deficits. So tight quadriceps is very common, tight hamstrings, calves. We want to address quad strength. So if they've been in a lot of pain and they might be walking with a quad avoidant gait, they're not going to be using their quads. They may have atrophy or having difficulty engaging it altogether, kind of lack that neuromotor control to engage it because they are so good, and kids are so good at hiding and creating habits without realizing it. And then we also want to do gluteal strengthening, clamshells, bridges, clocks, sidestepping. Treatment of OSD and SLJ. Core strengthening is really important, more so in kids than you think of adults because they have this decreased segmental stability at this point. And so we really want to make sure we're including planks, side planks, clamshells, bird dogs, something into our treatment. Neuromotor control, so single leg balance, static and dynamic. What's interesting is that there's no normative data for the adolescent population for how long they should be able to stand on a single leg. I think using the force plates as an objective measure to kind of see where their center of mass is a great tool to use because we don't have any kind of normative data. So it's a great way to track not only time, but their ability to modulate their posture in single leg balance. We also want to address their movement mechanics. So how are they initiating their movement? What's their symmetry? If they've had a lot of knee pain, they're probably not realizing that they're off weighting one side. And so being able to not only notice, not just from the naked eye, but using the force plates to determine if they're not putting weight on that leg. But then we want to train them to make sure that they are finding what equal weight bearing feels like. And then we want to gradually progress them back to full activity. So in creating your treatment plan, something you want to consider is sensory and motor considerations. In the young athlete, it's different than an adult. So somatosensory cues are critical for postural stability. The child and adolescent may have slower movement detection time, as well as decreased segmental stability, which is why we want to make sure we're always adding some type of core strengthening into their program. Multisensory re-rating mechanism. Children are less capable of adapting, slower to adapt, and adapt in less calibrated way to sensory conflict compared with adults, specifically with postural stability when multiple sensory cues are in conflict with one another. So they struggle more with crowded spaces when too many things are going on at once. Neuromuscular and postural control. Between childhood and adulthood, there is a shift from postural control from ballistic adjustments, greater in amplitude and velocity, to smoother, more frequent oscillations. This is what I was talking about in regards to their single leg balance. Being able to kind of train that ability to do postural corrections on the force plate is a great tool to work on that. And then less postural stability from anterior to posterior, so possible underdeveloped ankle strategy. We also want to talk about their coordination. So during adolescence, the athlete's ability to execute smooth, accurate, and controlled motor outputs will vary, and it is dependent on the complexity of the task. Their ability to develop more advanced anticipatory strategies will continue to develop at this time as they approach adulthood. So every kid is going to be a little bit different, but we definitely want to address their coordination and the way they're moving before we send them back to their sport. So addressing strength. Right here, this kiddo is using the Kinbent bubble. So it's a pressure sensor, a needle that is put into this bubble that can be put into a ball or anything. What's great about it is that you can use it to objectively determine his isometric quad strength, and then you can track that over time. If he is having too much pain to weight bear and do squats, this is a great way to just work his quad without having to create too much pain. As well as this game, what I really like about it is it's not only engaging for the kid, but I can change the level of difficulty. So this kiddo here is almost 7, and we set this up in probably 3 minutes. I feel like kids now are so good with iPads. You give it to them and they immediately have it working. With any kid, it's important to create a level that they are going to be successful at, but a little bit challenging. So with this game, he has 10 different levels, so I can change it according to how well he's doing. But I still have the availability on not making it too challenging. And as you can see, as he's contracting his quad and pushing down, his little character is going up and down, and he's trying to get the coins. And then another great thing about this is kids are competitive. Every kid wants to beat the next kid. So being able to keep beating his score is going to keep him engaged, because with working with kids, their attention span is a little bit, their attention span, they have trouble focusing for longer periods of time. So if you have a game where they have to keep getting better and better, it'll make them focus and want to stay on task and work their quad a little bit more. So looking at movement. So as we were talking about earlier, the importance of symmetry. In this video, I am doing a squat on the force plate. So first it determines where my weight shift is just in standing, and then it's going to determine if I'm able to maintain where I am as I go down in a squat and come back up. This is great for diagnostics of determining what my weight shift is, what percentage of it is. And then one of my favorite ways to use it is actually as a treatment. I'll turn the iPad facing the kid, and then I'll set it to like 20 seconds, and they'll do repetitive squats. And as they get tired, you'll notice that weight shift, but then they'll have that visual feedback to be able to adjust accordingly. And kids do so much better with visual cueing than they do with auditory cueing. So instead of saying, hey, make sure that you're equal weight bearing through your each foot, they have a harder time knowing what that is. So to have that visual cue to kind of physically see, oh, if I shift to my left, I'm going to be a little bit more this way, or if I shift to my right, the iPad is going to give them that feedback. The next video is of me doing single leg balance. So we talked about earlier how we don't have any normative data about how long a kid should be able to hold single leg stance for. That is definitely something we can track over time. But we also talked about postural control is a little bit delayed or developing in this time of their life. They're going from those ballistic adjustments with greater amplitude and velocity to smoother, more frequent oscillations. So you can track their center of mass every time that they're doing this. And so that is another objective value that you can look at as their postural stability or single leg balance is improving. And at the end of the video, it's going to give you that report for the clinician can see right here, the left and right foot, and you can see kind of greater center of mass right here. So I have a little bit less control on that left and smaller on my right. So a more challenging movement pattern is we're looking at jumping. So we can look at symmetry in a squat, and now we can look at symmetry with a jump or a squat jump, which is great because, like I said before, you can tell a kid, I want you to make sure you're equal weight, but they really have a hard time understanding that. And so to have that visual cue to be able to watch as they're going, okay, it looks like I was too much weight on my foot that time. And so having that visual cue instead of the clinician saying like, make sure you're more to your left, it's easier for them to understand. This is a way that you can use the force plates as a game for training weight shift. Again, using that visual cue as opposed to kind of telling them yourself. So in this game, this is pretty fun. He is a kangaroo swimming on a surfboard, and he's working on shifting his weight back and forth, trying to get the coins. And then he's also working on reaction time, which as kids are returning to sport, that's really important that they're able to improve that reaction time, make adjustments as fast as possible. And so I can, again, modulate this game from level 1 to 10. And again, it's really important with a kid that you make it just challenging enough that they can be successful, but not to the point where they get frustrated. Again, reiterating the importance of the external visual cues for kids. So this is a great squats and single leg squat progression. So with our kiddo here, he has a chair behind him to cue him to shift his weight back and use his glutes. And then we have cones in front of us to help tell him where he needs his knees to be. With OCD and SLJ, they have really tight quadriceps, and for that reason, they have a hard time getting their weight back. So as you improve that tissue extensibility, you now need to work on using their glutes and moving in that new range, and with a hip strategy versus a knee strategy. Then we're working on single leg squats. So instead of telling a kiddo, I want 80% of your weight on one leg and 20% on the other, you need to kind of create that environment for them. So we have him on a ball and he's working on going from sit to stand. And then to make it more challenging, you can have his foot on something that he can't put as much weight on, like a cone. And then the next phase would be doing single leg squats with a cone tap. So again, having that external cue of what he's supposed to do. So that is it. If anyone has any questions, either right now or feel free to email me at jilliankerickson@gmail.com. Please put Convent in the subject line so I know what it's from. And thank you so much for listening. So if we don't have any questions, again, please feel free to email me at jilliankerickson@gmail.com. Oh, maybe we do. Oh, we do have one question, sorry. How do you assess whether kids may be more over or under reporting their pain symptoms with exercises if they are engaging in the competition or game aspect of the exercise? With kids, pain science is a big thing of teaching them the difference between pain. You really have to ask them on the location, and you really have to ask them on the location, and then you have to compare side to side. So I do spend a lot of times poking each side, the injured side versus their non-injured side, and say, does this hurt? And does it feel the same as the other side? Also with kids, they have a hard time distinguishing between muscle pain, like the good kind of pain you feel from working your muscles or your quads, versus pathological pain. So for example, on that weight shift exercise, if the weight shift game where he's shifting back and forth, he's using his quads a lot. So a kid in that exercise could be complaining and rubbing their quads and saying, oh, I have a lot of pain here. And we talk about what kind of pain that is. Is that good pain or bad pain? If he says, oh, I have pain right here, and it's a very point specific, either on the inferior pole of the patella for Sitting-Larsen-Johnson syndrome or on the tibial tubercle, then then I'm thinking more he's overloading that structure, and this is a too challenging an exercise, and I need to make it easier. Good question. Okay, I apologize for any technical difficulties. I am new to this type of platform for webinars, but I hope you guys enjoyed it. And please email me with any questions.